Hello, my name is Idalia, or like everybody calls me, Nurse C, and today I'm here to teach you a little bit more about the ICU nursing routine and a little bit more about the ABCDE assessment that I do on my patients. Stay tuned if you want to learn a little bit more about ICU nursing, and I hope that you enjoy my video. Hi everyone, my name is Idalia, or like everybody calls me in nursing, Nurse C. I'm a nurse for the past 10 years and I've worked in several settings such as intensive care, cardiothoracics, wards, public health, and many others. And I'm really passionate about nursing, and I've decided to create this YouTube channel to put things that I wish I knew if I was just starting out, or if I was a student nurse, or even throughout my career. So I would like to share with you the things that I've learned and I wish I knew when I was on your stage of your nursing career. And today is the first series of the Creating Nursing Success and the virtual lectures that I prepare for you. And today is the ICU nursing routine. Bear in mind that context varies across countries, so depending on the country, your accountability, but also your level expertise will vary. And ICUs vary from ICUs, countries vary from your expertise and your requirements. So take this with a pinch of salt. I've done this being in the UK and working always in the UK. So take this with a pinch of salt, and I hope you enjoy what I've prepared for you. Comment down below if you like it or what types of other topics you want me to cover for you, and I'll try my best to do that, and the ones with most likes will be the ones that I will choose. So today we're going to start with the ICU nursing routine. This video is ideal if you're just starting out in ICU, want to understand a little bit more about what an ICU routine looks like, or if you're considering applying to ICU, or if you're a student nurse and you just want to know a little bit more about, how does it look like to work in ICU. So I hope you enjoy it. So what we're going to do today is look at the ICU routine, the handover, the bedside safety, the A to E patient assessment, the nursing care plan, medical rounds, and documentation. My approach to education is always through case studies. I love case studies, so each session that I'll make, I will always bring a case study for you. So today we have Nurse Mary that arrived to intensive care to work on a morning shift, and she is with Agnes, a current student nurse, and it's their first day in the unit. So how would you introduce ICU to Agnes? If you're a nurse starting out in ICU, if you had a friend, what do you think your friend will tell you if you're just starting out? I can tell you what I would tell you. ICU is an exciting place to work. I loved working in ICU, but it's a challenging place to work. It's very complex. It requires a lot of complexity of skills. In order to be on top of your game, you need to be studying and make sure that you keep your skills up to date. It's a very challenging environment, but it's a very exciting environment to work in. You deal with very complex patients. I think it's kind of rewarding for me to see them leaving ICU and getting better and see that they are progressing to get better. But it's not always like the best outcome. We have patients that die with us, and there are complex situations. So in those cases, for me, it's being able to enable a good dying process to patients and their families. But it's a lovely, rewarding place to work, and if you like challenges, if you like to learn, if you like to do a lot of technical skills, ICU is the place to be. So we're going to start with the nursing handover. So there's normally two nursing handovers. The first handover is you walk in, you sit down in a room, and then they will, the nursing charge will tell you, okay, the night was like this. This is how many patients we have. This is how many patients we are expecting. So many patients have, CT scans booked for today. This is how many transfers. And they will tell you, okay, this is the sickest patients. This is problem issues that we have with families. This is and this is going to be your patient for today. Then you go to the patient's room and you're going to have your nursing handover. So you're going to look at the patient's details, reason for admission and current issues. You're going to look at the ABCDE assessment, or you ask the nurse to do the ABCDE approach or whatever she does in her handover. Medication, pending clinical needs. So each nurse does the handover differently. I try to do as much as I can a thorough assessment so I don't forget anything, but I'll leave that to you and to your expertise and the type of unit that you are, and follow the guidelines and the recommendations of the units that you are. I follow this so I don't forget, and it makes it easier in my head. And sometimes if you're tired after a night shift, it's easier if you have already a thorough process that you go through so you don't forget things. All right, let me turn the slide. Okay, so as I said, case studies. I actually put a lot of pictures for people that work in developing countries because I've done this session before for people that work in countries less developing ITU. Although if you work in developing country, this is the same principles, is the same things. Probably people that don't have such developed ICU places might find this a little bit difficult. So if that's the case, please let me know on the comments below, and I'll try to do a much easier session for you so you can start from scratch. So basically, let's have a look at our patient. He's Brian, he's 56 years old, he works in construction. His next of kin is the wife. The reason for admission, well, chest infection a week ago, and came to ICU because he had high oxygen requirements and he's diabetic. As we can see, venturi mass 10 liters, wheezy, green secretions, doesn't look great, does it? 94 saturations, blood pressure a little bit low, not good. 100 heartbeats, doesn't look nice, does it? It looks like we are gonna have a busy shift. He's a little bit warm. His wound on the right hand to a fall, and he has no urine for the past 5 hours. Yeah, I think we're gonna be busy. And then in medication, he's on antibiotics, on IV fluids, and he has no sputum sample. He needs a sputum sample, and patient complains of pain. So these are the things that we might need to take into account. So when I do the handover, I always have a piece of paper with me or something that I write on to make sure that I don't forget the things that were handed over to me that need an action upon. The next thing I do is safety checks. Safety checks in ICU are very important, like in many other units and wards. Never underestimate safety checks, because if something goes wrong, if the safety checks are done and everything is done, you're gonna have a smooth process. So never underestimate the safety checks. Always do it. It's like being a pilot in an airplane. It's the same thing. You always have to do it. So we have an ICU unit here. First of all, before I enter the room, I'll check if there is any patient infection risk. If so, do I have enough material stock to come in and left for my colleagues when they come in? If yes, great. If no, I'll grab and go, wash my hands, introduce to the patient, and look at the patient. Does he look well at all? That's always my first thing. Sometimes if they are awake, when I was on the wards, I would say, hello, how are you? And I'll shake their hands because that would tell me, okay, are they cold, clammy, sweaty? So that tells me straight away a lot of things. So for me, that's very important, is to, introduce myself to the patient, and actually that helps me as well to understand if the patient looks okay or not. Then we're going to check the airway. So is the ventilator well connected? Check the ventilator, check all the connections. ATT size, tube secure, cuff pressure measure. So check all those checks. Then if he has a tracheostomy size, do you have any cannulas? Do you have the tracheostomy back with all the emergency needs? Check the chest drains as well. So if the patient has a chest drain, make sure that it's well connected to the patient. There's no air leak on the side. If it's on suction, is it bubbling? Is it swinging? Is he patent or not. So those things are also important. Is there any emphysema on the side, around the side? Obviously look at the emergency airway box as well, with all the materials that your unit requires you to have at the bedside. Look at the Warkit circuit. Is it connected with the oxygen? That's very important with the patient that is intubated. Suctioning, is the suctioning working properly? So you have the high and low suction, so make sure that you check those as well. Especially with chest drains, when you have them on low suction, make sure that they're suctioning properly. Then look at the Youngest suctioning. Do you have that connected? Do you have the bag properly set up? All those things. Then you will look at the lines. So you check the lines, administration rates, and connection sites. I always advise you, if you're just starting out after handover, make sure that you check all the lines before the nurse goes. This is because to avoid any mistakes that have been happening and you might not notice. So you can make sure that you have the patient safe before she leaves. Central lines and arterial monitoring, so check the side, check connections, 0 arterial lines, and check the bags as well. Make sure that the bag connected is the correct one and is not empty as well. And then check labels, connection sites, and VIP scores. Data is inserted specially. I would always advise you to check the dates of all the things. Make sure that they are up to date, because it's a key priority that our patients don't get any infections, because they are prone to high risk of infection. So we want to make sure that the lines are nice and clean and up to date. Then we go into the infection. We'll dump test. We will check the ID, allergies, and bins. So I always check that I have everything that I need there. And then last but not the least, you can't check what is written down, but it checks the alarms. So alarms of the monitor, alarms of the ventilators, alarms of every single thing, and adjust it to the patient, of course. So that's very, very important. You don't want to be in a situation where you set up the alarm to 20 heart rate and then the patient becomes bradycardic or low heart rate, and then you can't really pick that up. Imagine that you had turned around to do something. So that's very, very important. So now we're going to go into a patient assessment. There's different ways of assessing a patient. Some people say head to toe. Some people follow ABCDE. I think it depends on you and the types of units that you work in. Because I work in a critical care unit, I like to follow ABCDE for several reasons. First, because our patients normally tend to be acutely unwell, so all the areas are relevant. And head to toe is also useful if you think about it, but I like to start with the airway because the airway is the most important thing. But for example, if I'm on the ward, airway is unlikely to be a problem unless you work in an area with lots of laryngectomies and so on, or trachees. So you might start with the head to toe. I like to do this way. So on the airway, what should you see? Should ask, is the way patent? Is the patient self-ventilating? Is the patient talking full sentences? Well, if he's self-ventilating, he's talking full sentences, it doesn't look tired, it doesn't have any stridors or hoarse voice, and things look pretty good, right? Generally, in ICU, patients are intubated, so you need to check if, for example, on the ventilators, there is signs of lots of secretions on it, so you might see the waves a bit buckly, you might hear sounds. In case of full blockage, you might not hear anything. You just see the SATs drop if the patient is well sedated. So make sure that you suction as well. Does the patient have any airway adjunct in place? What type? So for example, with trachees, sometimes they get blocked, especially with patients with low secretion. So it's your responsibility to do a lot of nebulizers and suctioning to make sure that things are effective. Do we have any noisy breathing like stridor, gurgling, or wheeze that we need to be concerned of? Any signs of obstruction? Then we have specific checks for the ET tubes, for example, the date of insertion, the grade of intubation, the size of the ET tube, length at teats, tube secure, any size of pressure damage. if the available cuff pressure and entitled CO2 is important. Obviously, in developing countries, that's standard, but not in all countries is like that. Also, for tracheostomies, we also have specific checks. So we have the bedside emergency equipment available. Make sure the size of the tracheostomy, if it's surgical, if it's cutaneous, when it was last changing a cannula, when it was last changed the trachea, do we have any specific humidification, any signs of pressure damage as well, is the dressing clean and intact, when was the last time suctioned, and so on. So to the airway assessment, we might have possible causes of airway obstruction, and these were the ones that we tend to see in ICU. But majority of them that I see on the unit that I worked with was sometimes some bronchospasm following surgery, sometimes some foreign body, like a clot or something like that, a plug, sometimes some vomiting, patients vomiting, and that's it really. A block on the tracheostomy. They're very, very rare, but those are things that you need to be aware that can possibly occur if you work in ITU. And then in terms of airway adjustments to prevent airway obstruction, so for example, if you work in the recovery unit, you're going to use sometimes the Goodell's quite a lot, not a lot, but sometimes. And ANPs, for example, for patients that require help with secretions and suctioning because they might have a weak cough following tracheostomy extraction, for example. Okay, so endotracheal tubes. So this is what an endotracheal tube looks like. They might differ slightly on the way that they are built depending on the endotracheal tube, but this is kind of the standard that we have here in the UK. So this is the cuff to inflate the balloon. This is the size of the ET tube, which is size 8. And this is the length, and you should measure the length by the teeth or by the mouth. And then basically, things that you might do in ICU would be, for example, support the doctors and to prepare for intubation, help and support with the induction of the patient to prepare for intubation, and maybe support to deal with complications. So, but they tend to be rare, but they might happen. And there is 6 P's for the rapid sequence induction. So prepare, pre-oxygenate, pre-medication, paralysis, passage of the endotracheal tube, and post-intubation care. Your role as a nurse is mainly help with the setup of all the medications and drugs that are necessary, prepare all the material, and assist with the intubation. And it's very, very important as a nurse that you do these things properly, so we can have a smooth intubation process, and check your ventilation, prepare all the circuits, make sure that everything is ready. And if it's in hybrid immediately situation that you don't have things prepared for some reason that wasn't expected, maybe perhaps get somebody else to help you and coordinate things so we can have a smooth intubation. This is the things now that we're going to see and ask ourselves to our patient. Is the airway patent? It looks like it. I mean, they didn't told us anything that we might be concerned with the airway, speaking with us, talking with us. Is the patient self-ventilating? Yes. It doesn't have a ET tube. It doesn't have a tracheostomy. It's not connected to the ventilator. And it has a venturi mask. Is the patient talking through sentence? Yes, but quite tired. He stops between sentences to catch his breath. So, this is a sign that perhaps things, might be deteriorating, and we need to keep an eye on him very close because he's getting tired. And when patients get tired, might be an indication, if they continue like that, to intubate. Not always, but sometimes. Any signs of obstruction, choking? Not really. We haven't heard any concerns that would indicate that the patient is obstructing. Any noisy breathing, stridor, gurgling, or wheeze? Well, we have a little bit of wheeze, and that might be just because of how his condition that he's currently at, but nothing that is really concerning, and some nebulizers might help. Does the patient have any airway agent in place? What type? Not really, just has a venturi mask, 10 liters. And then obviously if the patient had AT tubes, this is the checks that we would do. And if he had tracheostomy, this is the types of checks that we would do. So my question to you, you can pause the video and you can think, what would you do now considering all the things that I've told you? What would you do to this patient? What kind of things would you consider? You can comment down below and maybe share with other colleagues what would you do on the comment section. See if you can learn together. And perhaps I can also learn from you too. So yeah, comment down below. See what would you do. Just comment what would you do or think about it. And I'm going to move on to breathing. On the breathing assessment, I always ask more or less these questions. Is the chest moving okay? Okay. Do I have bilateral expansion or do I have just one side expansion? Do I have something that looks off? Then I also assess the respiratory rate, rhythm, and that. Is the patient on oxygen or not? How much? What type of oxygen delivery system? I also assess the oxygenation saturations. I assess the arterial blood gases if you're working in ICU in an ICU that has arterial blood gases. I'm aware that in some developing countries it's not. I mean, just share with me, how it looks like your ICU in a developing country. I don't know, I never worked there, so you can share with me what types of settings do you have. And if you work in other countries, how does your ICU look like? You can always comment down below and we can share knowledge and different ways of treating patients. Then we look at the respiratory effort for any signs of distress. Are the patients using the accessory muscles to breathe? Seesaw breathing. Also auscultate chest if you have a chance to. I would definitely recommend nurses to develop their skills of assessing patients and auscultating patients. Is tremendously useful and important, and that will tell you a lot of things about the current patient situation. Then is the patient ventilated? What mode of ventilation? I'm going to cover this in another session. Tracheal secretions, when was last suction? The color, the type, the consistency. The specimen last sent. Did we send any specimen? Any forms of humidification? And does the patient have any chest drain? When was the inserted? Why was it inserted? Is the dressing okay? Is the connections okay? How is the chest drain? Is it bubbling, swingling, draining? Those kind of things. Then, obviously, I'm not going to cover this in detail. I'll just tell you that an important blood gas have an important role in ICU. And you should inform yourself, especially if you're going to start working in ICU, on how a blood gas looks like and how to interpret a blood gas. These are the key kind of main things. I forgot to put the lactate here, but lactate is very important. Normally it should be less than 2. And you can get familiar with concepts such as respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis, or a combination of both. But don't worry about that now. I'll do a video about this, and there's lots of resources online that you can also learn about. But it's definitely an important skill to have. As I said, auscultation as well. Make sure you learn how to auscultate patients is really, really important, and it gives you a lot of information. Very relevant. And even on the wards, if you work on the wards, there's always patients deteriorating every now and then. So get used to auscultate patients, especially if you work in a respiratory ward. And then I would like to talk as well about endotracheal suctioning and talk about a little bit when to suction. So I'd say that you should suction when you have audible secretions, when you have reduced saturation levels, when you have reduced spread of sounds or chest movements, depending on the case, coarse crackles on auscultation, not always is secretions, but changes in blood gas, cyanosis. So this is some of the reasons that you might need to suction. And why do we need to suction when patients are in ICU and sedated? Because intubation bypasses the normal respiratory barrier and the effects of sedation and impairs the cough reflex. So therefore, there's more risk of obstructing the airway and allow bacteria to grow. And obviously, the accumulation of secretions might cause airway obstruction, hypoxia, and cyanosis. And therefore, it's important to suction when required. So other things, is the chest moving okay? So assess this respiratory rate, so I can tell you that it has bilateral expansion. I can tell you that his respiratory rate is 30, saturations are 92. I can tell you that he's on 10 liters, past 2 days has increased from 2 liters, so not good. Then I can see that he's using accessory muscles. It has crackles and wheeze. Is the patient ventilated? No, but if deteriorates, might need ventilation. But there's other modes before ventilation that we can put him on, like CPAP or high flow oxygen. Tracheal secretions, no. He's not on humidification now, but maybe something that you can consider, right? And it doesn't have a chest drain. So once again, I want to ask you, what would you do? Comment down below what would you think you do for breathing. Exchange ideas with other nurses, add on what other nurses have written, or write it in a paper and see what kind of things you need to take into account. So I hope you could pause the video so you can think about things that you really want to do to the patient to make sure that he's comfortable enough and we can optimize him the best way possible. Following that, I will go to C, circulation. So this is some of the questions that I might ask and I might see, but let me highlight some of them. For example, you can look at if the patient has any cardiac drugs in progress. For example, common drugs in ICU are like noradrenaline, or if you're in a cardiac unit, dopamine, dobutamine, or adrenaline, or milrinone. Look at the ECG rhythm. So what is the rhythm of the patient? Is it sinus rhythm, sinus tachy, atrial fibrillation, flutters, so many SBD, so many things that it can be on. So you get familiarized as well with the cardiac monitoring outputs. Look at the blood pressure, central venous pressure. If you work in ICU, that requires that monitoring. So in cardiac ICUs, you tend to have that. Core temperature, urine output, and fluid balance, vascular access, and blood tests. So I always look at the blood tests as well to tell me exactly what's happening with the patients. Are the inflammatory markers going up? Are they going down? How is the kidney function? And so on. So once again, I want you to stop the video once I finish all these questions so you can think about what would you do in this case. You can comment on the section below on the comments, comment other nurses' comments, and think about what would you do in this case. So, is the patient clammy, cold, or warm to touch? I can tell you that is warm to touch. The pulse rate, rhythm, and strength, is tachycardic on 101 beats per minute with a blood pressure of 86/48 with a strong pulse. Is on sinus rhythm, in this case, sinus tachy. It has only non-invasive blood pressure. It doesn't have a central line. It has only normal saline running at 80 mils per hour. It has tazosine antibiotics. It doesn't have yet the arterial line or anything like that. His capillary refill is 2. His core temperature is 38.5. No problems with neurovascular observations, just warm to touch. And he doesn't have a catheter and he hasn't passed urine over the last 7 hours. Yeah, he has passed 7 hours. Fluid balance is 1 liter positive and that's it. And it looks dry and warm. So pause the video, comment down the section below what things you would do if you were looking after this patient, and exchange ideas with other nurses. Yeah, I forgot to add fluid balance over the previous 24 hours and vascular access and blood tests. So that's it. Pause the video, have a look and see what would you do. Okay, I hope you have reflected over the breathing section, the circulation section, and now we're gonna follow towards the disability. So disability, you can look at the Glasgow Coma Score, which has the exam of the pupils, verbal response and motor response. Is very, very important in neuro patients. I soon gonna check the session that I'm gonna do on neurovascular and working in neuro ICU, but this is extremely, extremely important. Look at the patient assessment, access type, location and severity of the pain, sedation assessment. So if the patient is sedated, use the RAS score, so you can understand the Richmond agitation and sedation score that I have here. Does the patient have any history of any convulsant, any medications for that, and check the glucose level. So once again, go back to our patient, and I can tell you that these pupils are brisk and equal 3, both sides. He's on 50 out of 15. He has a lot of pain when he coughs, and he doesn't been given any medication whatsoever. It is not sedated. No history of any convulsions, and blood sugar is 6. So now that you've checked the disability, and I hope you've commented below and share your ideas on things that you might need to look at for this patient, I want you to go into the exposure side. I would say that you can take this with a pinch of salt. As I said, each patient, each nurse is different, each unit is different. For me, it works best this way so I don't forget. So I tend to do any rashes or any wounds, and then I go to the gastro, any size of abdominal distension, any bowel sounds present, bowels left open. I tend to actually auscultate. So as I auscultate the lungs, I auscultate the tummy at the end. Then look at the nutritious status, any oral fluids, internal fluids. Is the patient able to eat, not eat? Does he have a dietitian plan in place? Any nausea and vomiting? Those are very important. And then, other things like, does he have any signs of vitae thrombosis, peripheral edema? What's the color of the mucosa? Pressure areas, eye care, mouth care, all those things. And when patient was last turned. And then, look at the patient's eye and mouth. It's very, very important. People forget. And hair as well. Hair, it's one of the areas that people forget so much in ICU. And it's so, so, so important. So are they dry? Are there any signs of infection in the eyes or mouth? Is there any candida present? Do you have eye and mouth care packs available for you to use? So once again, going back to our patient, any rashes or wounds? I said that he had a wound on the right arm. It has been dressed 3 days ago on the wards, but nobody really seen it in ICU. No signs of abdominal distension. He opened his bowels last 3 days and he has bowel sounds, and he's been, not eating very well in the last 2 days because he's been very breathless, so he finds it really hard to eat. And no other problems, just warm to touch. So once again, stop your video, share down in the comments below what you think you could do in the exposure, and is there anything that you would add up on your assessment? Feel free to add things up, and pause the video. And now we're gonna go to F. I add the F so I don't forget. F is for family and other needs. So any other spiritual and religious needs, communication aids required, check if the patient uses glasses, hearing aids. People sometimes forget to put it on, especially when patients are waking up. Who is the next of kin in the family? Are they aware of the admission and the current situation? Do they need an update? Next of kin details checked and correct. Very, very important. patient's property as well, so make sure that you have the patient's property documentation then as well. It's very important. So you can also pause the video here, stop and think about things that you would like to ask the family members about your patient, or any specific things that you want to assess on the F for family or other things, and pause and comment down the section below and see what else can you add. So there's a few online resources that you can use to look further and deep dive into the clinical assessment of a patient in ICU that I recommend. You have them here. But if you don't, I will develop our own with case-based studies as well. So let me know if it's something that you're interested in. Comment down below and I'll make plans to do one soon. So now we're gonna go into the plan care. So what I always do is basically I use the checklist of the ICU nursing checklist. I actually created one. You can find it on Etsy on the webpage Nursing Success, on the shop Nursing Success, and you can buy it for a very small fee, and basically you can share it with your friends. It's fine. But obviously help me out, because it takes a lot of hours to do those types of resources. And obviously you can also email me with the improvements that you might find useful. But I basically created that so you can plan your care, especially if you're just starting out. And I always think, is there anything missing from my checks? Is there any changes or questions from my medical team? Is there any medication to be given? What is the plan for my nursing care today? Nursing diagnosis, outcomes and evaluations, and interventions. So you can also stop the video again, think about all these questions, and you either can go and buy my checklist on Etsy that I have the links below and do it through there, or you can just copy these questions and put it on the comment section and just write something that you think that might be useful for you to think about, and maybe comment other people's comments and see what else can you add on their evaluations. So you can pause the video and I'll be back with the next part. So another thing you can think about is the nursing care plans. What kind of nursing care plans do you use? To be honest, it varies country to country. I studied in Portugal, and there they told me different theory. In some other countries they look at other theories. So I would say use the theory that you think that is most useful for you, so you can develop your nursing care plans, or depending on the area or the country or the hospital that you work in, just try to adapt the best that works for you or that the unit requires. So I would say that you can stop the video again. Feel free to comment below and tell me what would be your plan on a nursing care plan. I would say that, when patients are recovering from ICU, they're waking up, it's important to understand what they like, how can we distract them, how can we make their day more pleasant, how can we make them laugh, I think it's important to understand who is your patient and what do things they like, and what kind of things are we missing from them. Can we ask the family to bring it over? Things like that. So nursing routine. What routine would you have during the shift? Well, tends to be an hourly vital signs, ventilation, observation, fluid balance. If you are lucky enough to work in a unit where documentation is almost automatic, then great. If not, if you're still paper-based, it can take you about 10 to 15 minutes doing those. You do blood gas and blood sugars, maybe every 4 hours, depending on the case of the patient. 2 hourly turns, extremely important. We want to make sure that our patients don't get any pressure areas. And mobilize also helps with secretions. And obviously depends, this is a case of one of the countries that they do 3 hours bolus internal nutrition feeding. I wouldn't say that. Sometimes you have continuous feeding, sometimes you have bolos, sometimes you have bolos of water. It really depends. So once again, if you have anything to add on, you can add it on the comment section or write it in paper, and stop the video and think about what would be your plan for today. Maybe just write down hour by hour. So I started at 8 o'clock. From 8 to 8:30, I'll do my checks. From 8:30 to 8:45, I'll do my planning. From 9 till 10, I'll do this. From 10 to 11, I'll do this. So you can get used to the rhythm. Next, communication during medical rounds. I think it's very, very, very important for you to make sure that you communicate well with your medical team, because you are actually the person that stays with the patient all day. You are the one that spots deteriorations, spot things that haven't been done, spots things that should have been done. So it's very, very important for you to have a plan when they come in. And if the patient is not well, or there is something that you need to act upon, I like to use the SBAR tool to say that things that we need an action plan. So let's say I have a patient deteriorating, his SATs are dropping, blood gas doesn't look great, and the medical round is just coming in. If they weren't, maybe I have to go and tell them about it, and the nurse in charge. But let's say I could say, my name is Sidalia. I'm calling you I'm concerned because my patient is having low oxygen requirements, and is increasing his oxygen requirements, and his saturations are now 90% on 15 liters. Okay. Patient was admitted on X with a chest infection, and this is the last set of ops. I think the problem is, hypoxia, and I'm considering putting the patient on high flow oxygen. Is it okay if you come and see the patient and assess him, and if I could start him on Optiflow, for example? So maybe pause the video as well and see how would you communicate this patient deterioration that you're seeing to the medical team. And prepare your notes of things that you would like to see to the medical team about it. In terms of nursing documentation, it really depends on the units that you work in. But generally, you have the observation chart, the fluid chart, the medical notes, the line chart, the wound care plan, the nutrition, drug chart, and nursing notes. Depends on the units, depends on if they have a IT system or not, depends on lots of things. But I would say that trends are key in ICU, and document everything. I like to document everything. I check things. I check, previous notes of different multidisciplinary teams. I check everything. Sometimes it's not easy because we don't have enough time, but I try my best. And trends are really key in ICU. Make sure that you understand the trends, you see the trends, and see what's going on with the patient. Then it comes finally, after 12 or 7-hour shifts, the nursing shift handover. So I tend to follow the same approach as you are receiving the shift, but obviously you're now communicating, and try to make a standard to leave your shift as you would receive it. So I tend to make sure that I stock the patient's bedside, that things that are missing, they are there now. Try to do as much work as you can. So if lines have been expired, put another line, dressings, and so on. And if you have time, obviously if it's a busy day, then it's difficult, but at least you've done your best, or at least your colleague can see that you've done your best to do as much as you can to make, to leave the shift as you would receive it. And do you have any questions? Well, this is a virtual session, so it might be difficult for you to ask questions, but you can leave them in the comments below. And we are a group, we are a community, so you can leave it below, and I'm sure that other people will answer to you, and I'll try my best to answer if I see them. And just be aware, subscribe my channel, make a like button, click on the like button if you liked this session and if it was useful for you. Feel free to comment anything on the section below if you find that there's things that need to be improved, or if you like other types of sessions. And also, I'm setting up a community-based group soon, so keep an eye on my YouTube channel, and I'll have some news soon. Take care.
Hi there, thanks for listening. Like and subscribe for more videos.